Hello learners, let us discuss how does autonomous women's agencies support health choices. In the landscape of global health, India presents a profound paradox. While the nation has made monumental strides in reducing maternal mortality and expanding healthcare infrastructure, the agency, which means the actual power to make a decision, and the autonomy, which means the right to self-govern one's body, remain deeply contested territories for millions of Indian women. In many Indian contexts, a health choice is rarely a solitary act. It is a collective negotiation. Whether it is a rural woman seeking contraception, an urban professional choosing a birthing plan, or a young girl navigating menstrual health, their decisions are filtered through a complex web of relational autonomy. This means that a woman's choice is often bound by the expectations of her spouse, the authority of her in-laws, and the rigid scripts of caste and community norms. This module explored the critical question, who truly owns a woman's health in India? We will move beyond clinical statistics to examine the gatekeepers of health, the social and structural forces that dictates access and quality of care. We will look at how the National Family Health Survey 5 data reveals that permission remains a primary barrier to medical consultation. Further, we will critically analyze the medical gaze, where healthcare providers often transition from healers to moral arbiters, particularly when dealing with unmarried women or those from marginalized castes. Agency. Agency refers to the woman's ability to define her own goals and act upon them. In public health, this is often measured by a woman's voice within the household. Kabir, 1999, famously defined agency as the power within, which includes the processes of decision-making as well as less measurable manifestations such as negotiation, deception, and manipulation used to achieve health goals. As identified by Graham et al. 2019, agency in traditional or patriarchal household is not an isolated physiological trait, but a resource-dependent negotiation. A woman's health outcomes are frequently dictated by who control the three keys of access, money, mobility, and minutes. While agency is about the ability to act, autonomy is about the right to do so. In healthcare, this translates to bodily autonomy, the right to make decisions about one's own body without external influence or coercion. Unlike Western models that prioritize the individual, Indian social structure are built on relational autonomy. Decisions regarding pregnancy, sterilization, or even major surgeries are often collective family decisions. While this can provide a support system, it frequently leads to the erosion of women's individual consent, as the family's well-being is prioritized over the women's specific health needs. A critical pillar of this framework is bodily integrity. This is the principle that a woman's body is her own, and any medical intervention from a pelvic exam to a tubectomy requires informed consent. In India, the framework of autonomy is often underlined by target-based health policies. For decades, female sterilization was incentivized to meet population goals, leading to a corrected autonomy where women choose sterilization not out of range of options, but because it was the only accessible or socially approved permanent method. Finally, the framework must acknowledge that agency and autonomy are not distributed equally. A woman's degree of autonomy is heavily mediated by, number one, life stage. A mother-in-law generally possesses more agency than a new bride. Education. Higher education correlates strongly with the ability to navigate medical hierarchies. And third, caste and class. For marginalized women, particularly in the global south, the barrier to health is not merely a lack of individual will, but a state of structural disempowerment. This phenomena occurs when a woman's autonomy is systematically dismissed at multiple levels, first by the patriarchal family unit and then critically by the healthcare provider. The Indian joint or extended family functions as a collective unit where authority flows from the top down. Health decisions are centralized, meaning they are often debated and decided upon by elders or male heads rather than the person experiencing the symptoms. This structure prioritizes family reputation, financial stability, and traditional lineage over individual physical autonomy. In many households, the mother-in-law is the most influential internal gatekeeper. Her role is complex and dualistic. First, of the caregiver. She is the custodian of traditional postpartum care, example Sutika care, nutrition and infant rearing. Second, the gatekeeper. She holds the seniority in feminine domestic knowledge. A daughter-in-law often requires her explicit or implicit blessing to seek modern clinical interventions. Third, impact on agency. As Mumtaz et al. 2014 demonstrate, when a mother-in-law views a health issue such as chronic menstrual pain or the transition into menopause as a natural part of womanhood, she may actively discourage the use of formal medicine. In this framework, suffering is normalized as the inherent biological tax that all women must pay, rendering clinical interventions unnecessary or even indulgent. While the mother-in-law governs the social aspect of health, the husband typically governs the economic and logistical aspect, like financial control. As a primary breadwinner, the husband controls the funds for doctor's fee, medications, and transport. This creates a power to pay barrier. If the husband does not perceive the health issues as urgent, the women cannot access care independently. Second, the privacy trade-off. His involvement is a double-edged sword. While supporting husbands improve maternal outcomes, his presence as the transporter and payer erodes the women's privacy. In many cases, it is impossible for a woman to discuss sensitive topics such as reproductive health or domestic stresses with the doctor without her husband's knowledge or presence. Data from National Family Health Survey 5 reveals that limited physical mobility remains a staggering hurdle for millions of women in India. When a woman is restricted from visiting a healthcare center alone, her medical autonomy is severely compromised. The NFHS 5 2019-21 serves as a mirror to the patriarchal structure of Indian society. It measures empowerment through the lens of household decision making. Where a woman lacks the authority to decide on her own movement, her right to health becomes a granted privilege. Only about 71% of current married women in India participate in all three critical decisions: their own healthcare, making major household purchases, and visiting their own natal family. This means nearly 3 out of 10 women are excluded from the basic choices that govern their physical and social lives. True autonomy is often defined by the ability to move independently. The survey highlights that 18% of women, nearly 1/5 of the female population, are prohibited from going to a health center, market, or outside the community alone. The permission barrier is not the benign culture quit, it is a life-threatening clinical delay. In emergency medicine, this is often categorized as the first delay, the delay in deciding to seek care. Emergency obstetric care. In case of labor complications, minutes matter. If a woman must wait for a husband to return from work or a father-in-law to grant permission and provide an escort, the window for safe delivery can close. Infections and chronic pain. For non-emergency issues like reproductive tract infection, RTIs, or chronic pain, the permission requirement leads to silent suffering. A woman may decide the social cost of asking for permission and an escort is too high, lending her to suppress her symptoms until the condition becomes severe. Even when permission is granted, it is often contingent on logistical escorting. Because many rural women are not taught to drive or do not have access to independent transport, their mobility is physically tethered to male relatives. When a woman is taken to a clinic, the escort often enters the consultation room, effectively ending any chance of a confidential conversation between the doctor and the patient regarding domestic violence, sexual health, or mental well-being. Son preference acts as a stopping rule in Indian demography. A woman's reproductive career is often not defined by her own desire for a specific number of children, but by the gender composition of her existing children. Families often continue childbearing until the desired number of sons is achieved. This means that for a woman, health is sidelined by the cultural necessity of ensuring the family line, making son preference a primary driver of high fertility rates in specific regions. Research consistently shows that a woman's permission to use modern contraceptives is tied to her success in producing a son. Women with only daughters face significantly higher barriers to accessing contraception. Even if a woman is physically exhausted or identifies her family as complete, gatekeepers like husbands and mother-in-laws may veto the use of IUDs, pills, or sterilization until a male child is born. In a patriarchal household, the birth of a son often increases a woman's status and bargaining power. Without a son, her agency to negotiate for her own reproductive rest is severely diminished, as she has not yet fulfilled her primary marital obligation. When cultural scripts demand a boy, biological safety often takes a backseat. This leads to 3 specific health risks driven by social pressure rather than medical advice. Women are forced into a higher number of total pregnancies than their bodies may safely handle, increasing the cumulative risk of maternal exhaustion and hemorrhage. In the rush to try again for a boy, the critical recovery period between pregnancies, recommended to be at least 24 months, is often ignored. This leads to depletion of iron stores and higher risk of low birth weight infants, as mentioned by Balotra and Van Soest 2008. The result is a cycle of weathering, where the female body is prematurely aged by the stresses of repeated, closely spaced pregnancies. This is a clear instance where maternal morbidity is an avoidable outcome of a social structure, not a biological inevitability. In India, the patient-provider relationship is often characterized by extreme power asymmetry. Healthcare workers frequently adopt a paternalistic role where the doctor knows best mentality overrides the women's right to informed choices. Unmarried women seeking reproductive services such as contraception or abortion often face moral policing. Providers may demand the presence of a male guardian or counsel the patient against their choices based on personal morality rather than clinical necessity. This leads to forced counseling where women are shamed into specific behavior. In state-run facilities, the pressure to meet family planning targets like sterilization quotas can lead to providers pushing certain methods on marginalized women without explaining the side effects or alternatives, effectively stripping off the reproductive agency. The physical infrastructure of health in India dictates the level of privacy a woman can maintain. In rural areas, the structure itself acts as a gatekeeper. Due to scarcity of primary health centers in remote areas, women must often travel long distances. Lack of public transport forces them to rely on husbands or brothers for motorcycles or bicycles. This logistical dependency means the male relative knows the timing, location, and often the reason for the visit, making secret health choices like starting birth control or seeking mental health support impossible. In tribal belts, the lack of female practitioners who speak local dialects means a woman may need a male relative to translate for a male doctor. This eliminates any possibility of discussing sensitive reproductive information, leading to incomplete diagnosis. Caste is perhaps the most rigid structural barrier in the Indian healthcare system. Dalit and Adivasi women face intersectionality in crisis, where their gender and caste identity combine to minimize their agency. Research indicates that Dalit women often experience lower quality of care, longer waiting times, and even physical avoidance from providers who harbor deep-seated caste biases. When a woman is treated as impure or lesser, her ability to assert her rights or ask questions is silenced by the fear of being denied treatment altogether. Marginalized women are frequently the primary subject of mass sterilization camps. Their lack of economic and social capital makes them vulnerable to provider-driven choices, where agency is traded for small monetary incentives or state-mandated compliance as stated by Sen and Iyer in 2012. In India, female sterilization tubectomy accounts for nearly two-thirds of all modern contraceptive use. This is a statistical anomaly in global health where a mix of method is the norm. For many rural and low-income women, sterilization is viewed as the most efficient choice. It removes the need for repeated negotiations with husbands or gatekeepers, and it eliminates the requirement for regular travel to distant clinics for pills and injectables. Vasectomy, male sterilization, is safer, less invasive, and equally effective, yet it remains stigmatized and rarely utilized, like less than 1% in many regions. This places the entire biological burden of contraception on women, reflecting a social model where female bodies are seen as the primary site of reproductive regulation. The camp mode of sterilization has faced severe ethical critiques regarding the quality of informed consent and the preservation of agency. Historically, mass camps were driven by financial incentives and targets set for healthcare workers. In these environments, women are often fast-tracked through procedures without a full explanation of the permanent nature of the surgery or the potential side effects. A landmark Supreme Court ruling in Devika Biswas versus Union of India 2016 case highlighted the humanizing conditions of these camps, where lack of post-operative care and poor hygienic standards directly violates women's right to health and dignity. The court mandated the phase-out of sterilization camps in favor of the fixed-day services at accredited facilities. By 2026, the Indian government has accelerated its shift towards a right-based framework that emphasizes a broader basket of choice. The inclusion of long-acting reversible contraceptives such as progestin-only pills, Cencromin like Chaya, and specially injectable contraceptives like Antara and subdermal implants is designed to restore agency. These allow women to space births without committing to a permanent irreversible procedure. Modern policy focuses on quality of care, indicators rather than sterilization totals. The goal is to ensure that a woman chooses a method because it fits her lifestyle and reproductive goals, not because it is only option the state is offering at the time. The accredited social health activists, Ashas and Anganwadi workers model represent the most successful demedicalization of health in the Indian landscape. By utilizing women recruited from the same communities, these programs effectively bridge the vast social and cultural distance that often exists between rural women and formal clinical settings. Within the domestic sphere, Ashas act as critical negotiators who navigate the internal power structure of the family. Because they possess an intimate understanding of the local dynamics and cultural sensitivities, they can advocate for a woman's specific health needs such as institutional delivery or the adoption of contraception directly to influential family members like the mother-in-law or husband, as noted by Wade et al. 2019. This localized advocacy is often more effective than the advice of an outside doctor, as it speaks the language of the household to overcome traditional gatekeeping. Beyond immediate clinical outcomes, these programs foster a deeper sense of individual and collective empowerment. Research indicates that regular interaction with Ashas significantly increase a woman's self-efficacy and her confidence in articulating her own health requirements. According to Scott et al. 2019, this process effectively shifts health knowledge from the hands of the distant expert directly into the community. Digital health is emerging as a powerful structural bypass for physical gatekeeping in environments where a women's movement are monitored or restricted. In such contexts, the smartphone functions as a virtual private room, allowing for a degree of medical privacy that is often impossible in the physical world. As Pai et al. 2023 suggests, this shift represents a move towards digital agency where the barrier of permission to travel is replaced by immediacy of a screen. Mobile apps and telehealth platforms provide a discrete channel for women to seek information on sensitive topics such as reproductive health, sexual wellness, and mental health. This autonomy is particularly vital for young, unmarried women who often fear the medical gaze of the local community or the judgment of neighborhood practitioners. However, while the potential for empowerment is high, it remains currently skewed towards urban literate population. Pai et al. 2023 argues that closing the digital gender divide, the gap in device ownership, data affordability, and digital literacy is essential to ensure that technology does not become a new market of health inequality. To operationalize this philosophy, 2026 policy recommendations focus on dismantling the subordination trap within the labor ward and the clinic. A primary intervention is implementation of respectful maternity care charters. These charters move beyond clinical safety to reduce the right to dignity, informed consent, and freedom from the verbal and physical abuse that marginalized women often face in public hospitals. According to WHO 2024, the RMC, respectful maternity care, is not a luxury but a clinical necessity that directly impacts maternal mortality and psychological well-being. Thank you.